Hello, thank you very much for joining us at what's a really exciting moment for us as we launch the first evaluation of our work at James's Place. We'll have a short presentation of the findings, followed by plenty of time for questions and answers, which we'll take with the Q&A button that you should be able to see on your screen. There's also a chat facility if you'd like to comment throughout the webinar. So we have a panel here today, as you can see, and we'll start by introducing ourselves. My name is Ellen O'Donoghue and I'm the CEO at James's Place.
My name is Clare Milford Haven. I am co-founder and trustee of James's Place, and I'm James's mum.
My name is Jane Boland. I'm the manager here of the Liverpool Centre and the clinical lead of James's Place.
I'm Dr Pooja Saini and I'm the research lead at James's Place, and I'm based at Liverpool John Moores University.
Thank you. So we're going to start by hearing from Clare Milford Haven, our founder, and she's going to talk to us about how James's Place came to be.
Hello everyone, thank you so much for joining us today. It means a lot to us. Today, with the launch of our evaluation, marks a really big milestone for a charity that was born out of great sadness following the death of my eldest son James in December 2006. Just to give you some background, many of you know the story, but just to give you some background, James was a 21-year-old student at Newcastle University. He was in his second year studying business studies and Spanish. He was very easygoing, very jovial, seemed to have the world at his feet. But he had opted to have a minor operation in early December 2006. And this operation left him feeling very anxious, depressed, and ultimately suicidal. He went looking for help up at Newcastle with his worries. He went to a walk-in centre where they noted down on a piece of paper that he felt anxious and ultimately and he felt suicidal. And they sent him to A&E as a very low priority, as a priority 4, which is a bit like having toothache. He went to A&E and he walked out because he was asked to wait for a while. And when you're feeling anxious, I don't think you want to wait in that kind of setting. So ultimately, he didn't really get the help he wanted. I believe strongly that James didn't want to die because he went looking for help, but the help that he needed sadly wasn't available. 2 days after that, James took his own life. And as you can imagine, as a family with a son who had no history of mental health issues, this came as an overwhelming shock and turned our lives completely upside down. We decided to set up a fund in James's name because we wanted to try and prevent any other family going through what we were going through, which was a living hell. And so we set up a fund in 18 months after James's death, which we called the James Wentworth Stanley Memorial Fund. And we set about funding organisations and projects that we felt were very relevant to James. So they were mostly kind of university-based projects like Nightline, Student Minds, research projects, and anything that we felt was, as I say, very relevant. It was a huge learning curve for us. We had no knowledge of the charity sector. We had no knowledge of about mental health or suicide prevention. So it was a huge, huge learning curve. But all the time, I think it's true to say that I was reflecting really on James's story and on what happened to him on that day when he went looking for help. And I kept thinking, you know, what would have prevented this happening? And obviously one of the things that would have prevented it happening was if one of the people that he saw, one of the doctors, one of the nurses, had actually got in touch with me. That really would have helped. But that's a whole other story. But it was also the settings that he was seen in were very, very medical. And James was in a crisis. He was in a temporary crisis, and he didn't need to be seen in a medical setting. I feel strongly that he needed to be seen in a place that was warm and comforting and nurturing, but a place that made him feel valued and respected and not judged, a place that he didn't feel threatened at all, that he might be sectioned or restrained, or that something negative might go on his records. But that kind of place wasn't available. So I set about, I kept talking about this vision, and many of you perhaps were on this call. I bored you with that vision. I'm so sorry, for many, many years. But I felt so passionately about wanting to create a place, a space that would save men like James of all ages. And the first place that I looked at was Liverpool, because I had been contacted actually by Pooja, who you're going to meet in a while. And she contacted me, we had a chat about it. She said, come up to Liverpool. We really love your vision. So I went up there, and I was amazed that there was such engagement in something that was deeply personal to me, that hadn't really been thought through in great detail, but I was absolutely overwhelmed by the welcome that I got up there, and it just snowballed. And so we decided very quickly that Liverpool was going to be the first place that we were going to open. And James's Place was like a working title, but it's stuck, which is good. So that was all great, but the trouble was we needed to raise funds, and we needed to raise quite substantial funds to get this project off the ground. So my other son, Harry, stepped in and said that he wanted to commemorate the 10th anniversary of James's death by raising the funds for James's Place. So I said, well, that's wonderful, Harry. That's fantastic. So what are you going to do? Thinking maybe a 3 peaks climb or a marathon or something. He said, no, I'm going to sail the Atlantic with 3 friends, and we'll raise the funds that way. And I looked at him and I said, no, sorry, Harry, you're absolutely not going to do that. But my son is, he's 6'7", and he's very stubborn. And he said, I'm sorry, Mum, but we are. And so anyway, they talked me round, and they, after 39 days, I think it was 14 hours and 4 minutes, they arrived in Antigua, and they had raised over £650,000, which broke all records for that particular challenge, and meant that we could certainly open our first James's Place in Liverpool, which we did in June 2018, so just over 2 years ago. And it was, goodness, what a day it was. It was an amazing day. Some of you were there with us, and we were very fortunate that the Duke of Cambridge opened it for us. So that made it extra special, particularly with his commitment to mental health and suicide prevention. And since then, so in the last sort of just over 2 years, we have helped and seen over 400 men. And we have created that space, very much guided by a focus group of men. They got quite involved in the colour scheme and the interior design of James's Place. But we see these men in a setting that does exactly what I wanted, that is peaceful and calm and welcoming, and nurtures and values and respects them, and they don't feel threatened. And it's a place that men want to access, and men don't like accessing help, but they actually want to come to James's Place. And you'll hear from some testimonies later on that that actually they want to come back. So that's the background. That's James's story. That's our story as a family, my story. And I'm so proud of the data that we've collected. I've always felt it was very important we did this. And I'll now hand you back to Ellen, who will introduce the evaluation.
Thank you, Claire, very much indeed. So as you've heard from Claire, James's Place was set up with one clear purpose, which was to stop men dying by suicide. And as you'll all know, suicide is the leading cause of death for men under 50. And we believe that with the right support and provision in place, suicide is preventable. But without it, men are acutely vulnerable, and our work is to try to address that. We focus on men because the rates are so high, and our intervention has been specifically designed and co-created to treat and address suicidality in men. But we also want to build support, provision and knowledge across the sector. We want to understand what drives a suicidal crisis, what can be done to address it, and how to prevent it from occurring in future. So that's why evaluation, and particularly this report, is such a pivotal part of our work. Next slide, please. So you'll hear more in detail from Pooja and Jane as we go through about the intervention itself and the evaluation. But as a very top line, the centre opened in Liverpool 2 years ago, and since then we've seen over 400 men. And it was quite an extraordinary undertaking at that point, because it would give a kind of practical application to a fairly significant body of evidence around suicidality and its drivers. And so, you know, as we've said, since we've opened, we've seen over 400 men, and every one of those a very precious life and somebody who has been able to go on to find hope and to live their lives. But we've also had quite extraordinary access to understanding what these men have been experiencing during their suicidal period and in this incredibly difficult and vulnerable time. So by working with Pooja and the wider evaluation team, we've been able to really dig into this and formalise these findings. And so we use that constantly to inform the work that we're doing in Liverpool, and it will certainly be the basis of our next centre in East London. We've already been able to open virtually and are seeing a small caseload of men in East London. And we'll get the physical centre open as soon as possible, and at that point be able to significantly expand our caseload. Beyond that, we'll be looking to open more centres around the country. And evaluation is always going to be a key part of that. We will continue working with Pooja and the team at Liverpool John Moores University. We're also now working with UCL, University College London, and are building a kind of cross-London Liverpool evaluation model. And as we open more centres, we'll look to do ever more extensive research as we have a kind of larger data set to look from. Just finally, before we go into the kind of detail of the intervention, I'd also like to quickly mention the theory of change model. This part of the evaluation has been to look at social return on investment, and this has involved, I suppose, formalising our theory of change. And you know, this has helped us to understand the different stages, both the kind of the factors, the actions, the outcomes, the results of what we do. And whilst we can't put data against every section of this yet, it certainly shows the direction in which we'll be travelling over the coming years. And so I'm not going to go into great detail about this at this stage because it will be covered later. But what we're trying to pattern here is not only how men's well-being and mood and motivation are improved by the intervention, but also that their ability to understand their own problems, to understand how they're feeling and how they can talk about that really changes as well. And so while we see increases in well-being and we see reductions in thoughts around suicide, in suicidal thoughts and so forth, we're also looking at whether this equips them longer term to deal with the challenges that life lies ahead. So in terms of the outcomes, we can look, yes, at their immediate feelings, at their suicidality. We can also look at their likelihood, for example, to make an attempt and to recover. But even in the long term, in the longer term, we can also look at how this affects other health-related outcomes. How this affects, for example, their help-seeking behaviour, their ability to manage other periods of mental health and even physical health, and also the impact that this has on those around them. And so ultimately, that's going to be used to put a really clear value on the service that we offer at James's Place and that we provide to men in suicidal crisis. So at this stage, I'm going to hand across to Jane Boland. Jane is our clinical lead across James's Place and is also the manager of the centre in Liverpool. And she's going to talk to you about the intervention itself.
Good morning, everybody. Thanks for coming along. I'm sitting in James's Place today. I'd much rather be sort of welcoming you all here, but that'll come, I'm sure, when we're through this pandemic. So I'm going to talk you through how we got here in some ways, sort of leading on from what Claire talked about. And I think that when we had those conversations about what James's Place would do and who we would treat, we were quite clear about where it would sit in that kind of crisis pathway. And we were quite clear that it wasn't replicating something that already existed. We feel that it complements what already exists. We've found a niche, we found a sort of an unmet need, and we certainly feel that we're meeting it in Liverpool. So the men who see us would typically be experiencing an intensity of suicidal distress that would preclude them really from treatment at sort of traditional IAP services. But their distress isn't driven by a serious mental health problem. So psychiatric services would also be a poor fit, and that's where we fit in. So these are men who with more traditional services aren't finding the help. If they are looking for it, they're not finding it, and in many cases they're not looking for it. That was what the research was telling us before we set up James's Place. And our service is for these men. So the men that we see men or people who identify as men. They're adults, 18 plus. They identify that they're experiencing a suicidal crisis. That can mean that they may have tried to kill themselves in the run up to seeing us at James's Place, or they may be at the stage where suicide is becoming for them a very viable option in terms of what they can do next. They have to be registered with the GP. We work quite closely with our services. They have to be able to access accommodation. They have to be able to engage in talking therapy. So we do have some referral criteria, but we try to make it as our reach as broad as possible. We'll also sort of really struggle to work with somebody who's sort of active in addiction. We do work alongside addiction services, but if somebody's not addressing their addiction, I think we'll be quite hard pressed to offer them a therapeutic intervention. And so that's who we're for. And then we've developed the next, and these are the people that we've sort of developed our referral pathways with in Liverpool. So we started off when we opened back in 2018, which seems a very long time ago now. We started off by working with the local A&E teams from Merseycare and the walk-in centres, and we did quite a lot of work with them. They really do understand what it is that we do here, and their referrals to us are sort of very, very key to what we do, because they really understood how we do fit into that kind of crisis pathway. We've also worked with university health services. We're quite lucky in Liverpool. We've got a huge GP practice that covers 5 centres, and we've got very close links with them. And eventually, probably after about 6 months, we went wider and we went to sort of self-referrals. Next slide, please. So when we were thinking of what we were going to do, so like I said, we had in Clare and Nick a vision of what they wanted to happen and where they wanted it to happen. And the intervention or the treatment that happens within James's Place has to be in step with the beautiful environment and with our ethos that you have to support the supporters as well. So when I was thinking about what we needed it to be and what the men needed to experience when they come here, I knew that we had to sort of, we had to look at sort of resolving the crisis. So I knew that it would be quite a short-term intervention. I knew that we had to involve supporters. We had to bring those people in and get this problem shared. We were very much talking about psychological and practical support. So we're not medics. This isn't a psychiatric intervention. And I knew it was going to be formulation based, because that's kind of my background and the work that I was doing previously. But I guess that I knew that the formulation had to be very collaborative, that this was about working alongside men to help them to understand how they got into the crisis. And I knew that there was an evidence base there as well. So I knew that the work of Joyner, his theory, and Jobs over in Canada, and Rory O'Connor, I knew that the academic reasoning, the language was all there that could support our thinking and what we were going to deliver. Next slide, please. And this is sort of an overview of what our model is. So the first sort of contact that we have with the men is getting them to think about whether we're the right people to help you, and if we are, we work with them through this process, understanding how they got into the crisis, what they can do to get through it, and how they can stop it happening again, and the next steps for them about continuing to maintain good mental health. And how do we do this? So that's our next. So they're taken through this intervention, and the focus is on sharing understanding and providing emotional and practical support whilst they're with us, really focusing on problem solving. And that's how we use our formulation. And our formulation takes somebody, we have a set of cards with lots of different words on, from, you know, some of the language on the cards, it's quite hard hitting. I want to kill myself. I think of dying. You know, nobody cares about me. So we use these cards to prompt the men to think about what's happening to them, what they're feeling and thinking. And we work with them to put those thoughts and feelings into context. Can I have the next slide? So this is a very sort of quick version. And these were actually the slides of a man that I was working with a while ago now. And when he was talking to me, he was trying to make sense of what he was going through. And he kept talking about how he was a terrible person. And he kept talking about the decking in the garden. And he was sitting in his kitchen looking out, and the decking was broken, and he couldn't fix the decking. He couldn't make himself go out there and fix it. And this decking became sort of quite totemic for him. He was such a bad person, such a bad dad, such a bad husband, because he couldn't fix the decking, that he tried to kill himself. He was at the stage where he was thinking that was, if I can't even fix the decking, I may as well just kill myself. And you know, that's an example for me of how so often the problem that the person thinks is the problem, A, seems really sort of quite out of kilter with the distress that they're feeling, and B, often isn't really the problem. So when we were able to break down what he was thinking and feeling when he was saying this, if I can't fix the decking, what's the point of me? Then it was like he wasn't sleeping, he was feeling very ashamed, he didn't want to be here. And just those 3 cards gave us a chance to start really sort of picking out what it was that he needed to happen. So as part of our intervention, we did some simple work around sleep hygiene. We looked at what was happening. We looked at what he was doing before he went to bed. This is all quite recognisable things that people will have used in other interventions. When we talked about him not wanting to be here, you know, he was very much feeling very trapped by his situation. Once he started talking to his partner and to his dad and to other people in his life, he was able to sort of share his problems with them and started feeling that he didn't want to be around. He didn't feel like a burden. And that's how we've used the cards. And the cards are sort of an integral part of our intervention. And what we've done in Liverpool and what we will be doing in London is that the therapists who come to work for James's Place come to us as skilled therapists, but not as suicide prevention therapists. And we teach them this intervention, and this is how they deliver an intervention that very much focuses on that suicidal crisis. Can I have the next card, please? And the kind of the feedback from the men has been quite astonishing, really. And I think it's available on our website, sort of a recording of men talking about using the cards. And it was quite sort of emotional for me to hear them talk about it and how powerful they found the cards as a tool, and how the men have adapted the cards for themselves. Some of the men, you know, take them away with them. Some of them take pictures of them and then they share that with family members because they can't express how they're feeling. But once it's literally laid out on the table, they're able to sort of say, this is why I'm feeling so terrible, because of all of these thoughts and feelings that are going around in my head. And you know, the therapists have found that the cards are sort of the structure of the intervention. And interestingly, although in many ways we are working towards not manualizing so much, but that the intervention is a process that men go through. We know how many sessions they probably need. The men don't seem to experience it as anything other than feeling very personal to them. So I think we somehow seem to be sort of hitting that quite right between, you know, knowing that there's a structure, but not making the men feel like they're sort of being pushed through a process. Next card one. So Pooja's going to go into more detail about the evaluation. But I suppose I just want to finish. When I started and kind of almost sold my idea of what an intervention would look like to Clare and the trustees, I was confident that it would work. I was confident that we would be able to help men to change. And you know, we were very clear that we were going to evaluate from the very beginning, even though that's quite scary to do. You know, you're putting something out there as a theory, and you sort of, you know, because we could be sitting here telling you that actually it had all gone terribly wrong and we're rubbish, but we're not. So we were collating the data that Pooja sort of analysed, but after sort of a few months, we had a look at the outcomes that were coming through, and we were quite astonished. And I just want to show the next slide, please, Francoise, because what we saw was a huge change. So I was very hopeful that we would be taking people through kind of one stage of change on the core. So I was thinking that we would hopefully be taking people from moderate to mild on this core OM score. But what we in fact found, and what we have continued to find, is that we're taking people from severe, and you know, that's our average initial core. It gets a lot higher than 85, and then we're taking them to mild, and in many cases we're actually taking them to sort of low and healthy, and I think that we've been quite happily surprised by how well the intervention has worked with the men who've gone through our service. So I'm going to hand you over to Dr. Saini, who will sort of go into more detail about the evaluation. Thank you, Pooja.
Thank you, Jane. So yeah, if we could go on to the next slide, please. So, you know, as everyone has mentioned before, we really have based a lot of the work at Jane's Place on the evidence base. We know that suicide is a major public health risk and that rates are rising in England, and with males being in the high risk group. And one thing that came out of my previous research, I did my PhD at the University of Manchester at the Centre for Mental Health and Risk, and focused on the role of primary care within suicide prevention. And one thing that really came out was that many of the prevention services are incompatible with the needs and preferences of men. And with many of the general practitioners, they spoke about men coming in and communicating with them. So the issue didn't seem to be the lack of help seeking or the lack of communication, but it was actually what was then relevant to refer them to. What we've also found is there's very few evaluative studies that look at the effectiveness of the implementation of suicide prevention programs that are targeted towards men. Now, this could be because there aren't many to evaluate, or because some of the services are based more within third sector organisations, voluntary organisations, which aren't necessarily always evaluated. So that was one key aspect of Jane's Place we always felt was important, was we need to have evaluation in here from the beginning. And again, like everything else, we've co-produced which measures we should be using, what was important to find out from the outset. So I'll go into that in more detail now about what the aims of the study were and how we collected the data. So the main aim for this first year evaluation was to see how men were finding the service that was being delivered, how the therapists were finding delivering this intervention, how it was working within a community setting. Because, you know, I know from my research within suicide and self-harm, there is some resistance about interventions being delivered within community settings. So that's another really important aspect we wanted to find out. So we'll just look at the methods of our evaluation. So we designed a cohort study which basically followed the men who used the service within the first year since it opened in August. So it opened in June 2018, but we actually started seeing men there from the 1st of August 2018, and we collected data up until the 31st of July for the first year for 2019. I'll go into more detail about how many men were referred in, but we had 265 referrals in the first year and 176 men who then went on to engage in the therapy. And the intervention, as Jane has described, was for men who were in suicidal crisis. So the outcome measures that we used, the first aspect was a clinical service data that was collected in-house at James's Place. And we tried to ensure that we covered all the kind of demographic information, some of the clinical data we might need that has been evidenced in research before. We also had incident logs of anyone who had hurt themselves within care, whilst they were within the care of James's Place. And the decision for the Core 34 outcome measure was made because that was also used by our local mental health trust, and it was a validated tool to assess and measure psychological distress, and it just seemed quite appropriate to use with the men. As well as that, we've collected feedback questionnaires from the men who've used the service, also feedback from the supporters of those men, and we have conducted some interviews with the men and supporters over time. We've used statistical methods to analyse all of our data. We've used some scientific software called SPSS, and we've looked at examined the client outcome repeated measures using general linear models to compare the pre and post treatment. So for the people who completed the questionnaire I mentioned earlier, when they got assessed, when they came into the service, and also at discharge when they left the service. So next slide, please. So when we look at actually how many people came and used the service, we've got a bigger breakdown in a minute for the referrals from each of the places of emergency departments, primary care, universities and self-referrals. And 212 actually attended for the welcome assessment. So some people didn't come for that. And 176, so 83% of those went on to engage with the therapy. And the mean age of the men was 33 years with a range of 18 to 61. So we'll look at some of these figures in a bit more detail. At the moment, we haven't got information on why some of the men didn't attend, but some anecdotal feedback for some people when they did attend the welcome assessment was they actually felt quite happy knowing that there was somewhere they could go if they did feel worse again. For some men, they had to be referred back to secondary care because they needed to be assessed there again or possibly admitted to hospital. But that is an area we would like to collect more data on in the future for the people who didn't attend at the centre. So we have the next slide. Yep, great, thank you. So referrals, as we said, we started off with referrals from mental health practitioners in A&E. So it's not surprising that we had the highest number from there. So over a third of the referrals were from mental health practitioners. Unfortunately, there's a lot of data where we didn't have it specified where the referrals came from. And I think with this just being a new service, you'll see as we go along, there has been some issues with missing data. So we've now got a system called HeyDoc, which is a clinical data system online, which will hopefully reduce the amount of missing data we do get in the future. But we've got a breakdown here. We've got quite a lot of referrals that came in from general practitioners. The self-referral started later on, as Jane mentioned. And then there's other areas where we have had some referrals coming in, and student health seems quite low, but actually quite a few of the self-referrals or referrals via general practitioners were for students in the area. Next slide, please. So if we look at the breakdown of the age range, you can see here that many of the people who attended at James Place were younger. So we had over half who were under 34 years old, so between 18 and 34, followed by men in the age category of 35 to 44. And we had a lot less men coming in the older age group. So from looking at the numbers and actually using this data, one thing that has happened at James's Place is the service have had more communication with local referral like general practitioners, to understand why less referrals are coming from there, or to encourage more referrals to come from this age group, which we also know can be quite vulnerable and at risk to suicide. Next slide, please. Thank you. So some of the demographic data here. We didn't have any significance with any of the demographic data and the core outcomes measure. But as you can see, the majority of men using the service are white British. Many were single, but that also includes people who were cohabiting or in relationships. So the category just wasn't there to list them. So I think that's a bit of an overrepresentation. For sexual orientation, most were heterosexual. And we had more of an even spread with employment status, which is probably, more newer for what we would have seen with some of the research evidence that shows that unemployed men will be more at risk. So here, as you can see, we have actually had a lot of men engaging who were employed as well, and a fifth of the sample were students too. So Jane mentioned the core outcome measures before, and how one of the kind of, I suppose, surprising findings and really positive finding was that men were coming in at severe levels, and many of them were going down to mild or low levels or even healthy levels. And I think it's really important to emphasize that this is an area where general practitioners or other practitioners wouldn't see men needing support when they're being brought down. So the service is having a huge impact on helping to reduce the suicidal risk in these men over quite a short period of time. And we'll just look on the next slide at some of the statistical analysis of this data. And what we can see here is for all of the men, or majority of the men that use the service, we can see a clinical significant reduction in all of these outcomes here. So general distress, subjective well-being improved, problems and symptoms improved, their life functioning improved, and risk and harm reduced. And these all reduced, as I've said, clinically and significantly. So I think that's a really important finding for us for the first year, to show us that the intervention does seem to be working, and that we have got some positive, significant outcomes to evidence this. We also have looked at some of the factors related to, why the men felt they were in a suicidal crisis, and what they'd reported either within their sessions to therapists or what they reported when they first came in. So as we can see here, relationship breakdowns are some of the highest, family problems, including domestic abuse. And many of these risk factors are quite prevalent within the research as well, and they do really marry up with a lot of the evidence that is in the literature. But I think one area which is really interesting in how the service have helped some of these men is, once they know that somebody has an issue with debt, they've managed to link them up maybe with some services locally that can also help with this issue, as well as them helping the men when they're in suicidality. For bereavement, we've had the local commissioning group actually provide a small amount of funding because they've seen evidence of men coming in with some issues to do with bereavement. For drug and alcohol, as Jane mentioned before, we can work closely with some of the local services, and we've definitely got a close relationship with the universities in Liverpool, and James's Place is spoken about within some of the freshers fairs and things. So we can now use this data to actually think about which services should we be linking up with, and where should maybe some of the future work lie as well. Next slide, please. So we'd just like to play an audio for you from some of the men who've used the service.
James's Place felt like someone's home, and they were welcoming you in. It felt safe there and clean, and it looks really nice. Keeps you at peace a bit more.
The warmth, you can feel it as soon as you walk through the door. The people in there are amazing. I can't thank them enough, to be honest with you. They rebuilt me. It was completely different to what I've been used to. It was more like speaking to a family member and a friend than a therapist type of thing.
I don't know where I could have gone for help if I didn't go to James's Place, because I'd tried other things around Liverpool.
I'm scared to think I mightn't be sitting here today if I didn't know where James Place was.
I wasn't going anywhere, to be honest with yourself. I had one thing on my mind and one thing going on. I wouldn't have survived. I couldn't recommend it highly enough. It's a fantastic place.
I think one of the things with a lot of men, especially like men my age and older, we don't talk and we struggle to talk, and it's probably one of the better things to help us get better.
If I thought someone was that down, I'd drag them there. I'd do everything physically possible to take someone there, because I know it's helped save me.
I've been in that place before, I've been where you are now, and James's Place can help you get through it.
Thank you for that. So that leads us on nicely, really. We've included 2 case studies today. We've obviously used pseudonym names. And, you know, they allude to some of the points that you've just heard to, but we wanted to take you through 2 people's experiences from when they engaged with James Place to when they've been discharged from James Place as well. So I think the first thing to emphasize was that the men kind of alluded to the fact of not knowing, actually, maybe how serious some of their thoughts were. And some of them didn't know about the centre, so you know they were quite nervous about coming in, but they did feel that once they knew about the centre, they were happy to come and engage. And when they started to receive therapy at James Place, some of them spoke about using the cards and how suddenly they would actually visually see what was going on within their minds, and actually, you know, they suddenly thought about, well, no wonder I'm feeling this way, and no wonder I've had these thoughts, and it started to maybe make some more sense to them of why they might have been feeling this way. And it also, in some cases, for this example, it emphasized to this person who'd put all of their distress on the fact that they'd lost their mum a few years ago, that actually there were a lot of other things that were going on in their life that had led them to these feelings. If we just go on to the next slide. Many of the men who spoke about comparison to other settings, I think one person just said it then in the recording, it just feels like when they all talk about it, that they just say it didn't work for them. And as this gentleman here says, that he didn't want to feel ungrateful, but many of them just said the setting didn't work for them, the type of CBT courses they were sent on, both of these examples talk about that, how that just didn't work for them. Being in an office setting, not connecting with the environment. And that seems to have been a really important factor at James's Place. You know, I've heard other men talk about the environment actually helping them to open up to therapists. We also wanted to find out from the men if there was anything that they could suggest for the changes to the therapy. I'll be honest and say many of them really found this difficult to answer because they were so happy with the intervention that they had. And usually when I'd interviewed them, they'd been through the intervention and they'd been discharged from the service. So I think many of them actually just provided some really practical pointers. So this man brought up about the fact that it's not 24-hour, it's not at the weekend. So maybe there could be some development of having a hotline. And there is actually a crisis text line that James Place is connected up with, where we can provide some of that support. And if we look at the impact, I just felt like everything was on top of me, and I really just couldn't feel like if I drew a picture, I would have just been sat in the corner with a rock on top, just weighted down by things. Now I feel so light and a different person. And I think that says it all, really, of what an effect this intervention had on them. And if we look at the next case study, to do with Liam, so he found out via his doctor, and he had a look at the service online, and he got in touch and he had an appointment. And many of the men did talk about, you know, feeling quite anxious about coming because they hadn't heard of this service before and how it might be, but that they thought they'd give it a go. And when he spoke about receiving the therapy, you know, he felt he was ready to have a go, but he did say that he couldn't talk to his family about some of the thoughts he was having, some of the feelings he was having. You know, he just wasn't that type of person. He was quite guarded. And when he spoke about the therapy tools, you know, he talked about how much he reflected back at the plan that he did write with his therapist, and that he'd look back at the cards, and he'd taken pictures of the cards, and he would go back and revisit them when he was feeling like some of those suicidal thoughts were creeping back. And he talked about kind of enjoying mixing them and matching them, and having a look at different ones and seeing which ones could help him through at different times. So he liked the flexibility and the variation of the cards that were available. Next slide, please. So again, you can see here, he talked about the CBT course, which just didn't seem to work with him either. And again, he felt it scratched a service, and many men spoke about some of the other services they'd been in that were group settings that they didn't feel comfortable speaking about some of their thoughts and feelings in, or about the long waiting lists. And this interview was actually conducted when lockdown had just started, so this man was even more concerned about how the waiting might have been even longer. So this man spoke about how upsetting it was, the thought of being discharged from James Place. And, you know, he said it felt like he'd be going there to have a chat with his mates. And he never felt uncomfortable speaking to them about his feelings, but he did understand that it had to come to an end. And he would use his tools to keep reflecting and looking back at. But, you know, he talked about it in a really positive way of why he didn't want to leave. And it was more the fact of feeling like he had someone to talk to as a friend. But he also spoke about the fact that he was speaking to his family more after engaging with James's Place. And if we look at the impact it had on him, you know, I think the first sentence says it all really: I might not be talking to you now. So that's the sort of impact that it's had. And he definitely said he'd be telling other men to use the service if he ever came across someone who was feeling the same way. Next slide, please. So we also did some evaluative work with some of the supporters of the men who were using the service. I haven't provided all of the data here, but one thing just to note is we did collect data on anxiety and depression, and all of the supporters did seem to have much higher levels of anxiety and depression that we spoke to and collected data from. But many of them shared about just feeling supported by James's Place themselves, and the fact that they could have someone to talk to when they were kind of second guessing how the men were feeling. And many people spoke about, you know, kind of standing outside the men's door at night because they were so worried. But just knowing that they were engaging well with a service like James's Place, and the fact that they could also be involved in the therapy and the intervention going forwards, they really found that reassuring. Another person spoke about the reassurance that if they went away, they felt a lot more comfortable than they ever had done before, just knowing that James's Place was also engaged with the man who was feeling suicidal, and just having someone at the end of a phone who's kind and supportive. And I think it's really important to bring up the men as well, fed back about how kind they found the therapists and supportive too. So the next slide, please. So if we just summarize the findings, really, the whole point of the evaluation was to see, is this intervention going to work? Can the therapist deliver it? Do the men, does it work with the men? And are we going to see any reduction in suicidality and improvement in their outcomes? And the results definitely support the James Place model for men in suicidal distress, you know, potentially preventing suicide in this high-risk group of the population. The brief psychological clinical intervention can be delivered in community settings and effectively reduce suicidal risk. And if anything, I'd say it was preferred by many of the men, and I think that came across in the feedback. We've also accessed men at the time of their suicidal crisis, and that seemed really important. And we've got a lot of learning to do from that information, and we're still conducting a lot of research to understand more what could be helped for future interventions. And for future research, we really want to look at the long-term effects of the model in order to understand whether it's sustainable over time. And we've currently got a fully funded PhD that has started that will be looking at this in more detail. So thank you very much. And I think we'll be passing you back over to Jane and Ellen now.
Sorry, Zoom delay there. This seems to happen on all of these calls. I just wanted to quickly sort of talk about sort of slightly more wraparound support that we are developing. Our main intervention is our main intervention. Our core business is delivering our one-to-one intervention to men in a suicidal crisis. But we have also gone on to develop additional extra support. We've got an amazing bunch of volunteer mentors who came along and have volunteered their time. We've trained them how to be James's Place mentors, and men who are going through our service who perhaps don't have somebody who they would identify as a supporter. We give them the option to have one of our mentors support them. That can either be telephone support, or sometimes I'll come in and catch up with them at the centre when we were sort of before the pandemic. And the mentors are really skilled. They're not therapists. They will typically perhaps help some of the men with sort of practical things that are going on, perhaps with form filling or looking on websites and stuff. But they are an untapped resource. And I think as we really hit our stride, as we go back into the new year and we start sort of getting over this pandemic, I think the mentors are going to really sort of come into their own. We have extra support. Pooja talked about the impact that going through a suicidal crisis has on the loved ones of people who are going through it, and we do specifically offer support to supporters. So all supporters are offered like a one-off kind of catch-up session with one of our therapists, not the same therapist who's seen their men, to talk them through what is going on, point them to sort of other resources if they're available. We will have a support group for supporters when we're able to do group activities back in James's Place, and that's the same for our sort of peer support. We had a plan to start a group for men who have been discharged from James's Place but who perhaps feel that they need a little bit of a top up, but they don't need to come back and see us, but they would just like to sort of have some ongoing support from each other. So they're not happening yet. They were just about to happen, literally, but the one-to-one support for supporters is in place and is, I think we've offered something like 15 sessions have been picked up from people. More information about those programs will be included, I think, in year two's evaluation, not so much year one. But that's sort of some of the extra things that we're doing at James's Place as well. And I'll hand you over to Ellen now.
Thank you very much. So you've heard a lot from us now, and I want to give plenty of time for the question and answers, so I won't keep you long here. But I think just in summary, and to be clear, we believe that this evaluation does show the effectiveness of our model, and it will be what we use to go on to open new James's Places, starting in London, where plans to open are well underway, as I said, but from then on also to open other James's Places around the country, so that we can really save more lives and build the evidence about what works to address suicidal crisis. And so evaluation will always be an integral part of that, and so will partnerships. So we're really grateful to all of you for being here today.